All right, let's see if my slides will advance. Here we go. So my learning objectives are going to be to look at some clinical guidelines for the diagnosis of pneumonia and show you how tricky it is. What is the role of some of the new technologies, including the semi-quantitative bacterial report that we can get from some of these pneumonia panels that help guide us, but more importantly, how to interpret the results of those panels. Now, I always like to start off, I'm obviously very much into diagnostic stewardship as well as antimicrobial stewardship and antimicrobial resistance. And I love this particular slide that was created by the AHRQ Safety Program for Improving Antibiotic Use. That was a project done in 2018 and 2019, which I had the privilege of participating. And it's the 4 moments of antibiotic decision-making. And the first thing we have to decide when we see a patient that may have pneumonia is, does the patient actually have an infection that requires antibiotics? And you'll see that we now know that viral play in a role in pneumonia. Have I done the appropriate cultures before starting antibiotics? And what's the best empiric therapy should I initiate? And then every day after you start antibiotics, is there an opportunity to stop it because you haven't identified a bacterial pathogen, or can I narrow the spectrum, or can I actually change from an IV to an oral drug? And then lastly, but very importantly, the duration. We've learned with many of the common pneumonias that shorter duration is as good as longer duration, and it's safer. So the diagnostic challenges here of lower respiratory is, number one, we now know that multiple pathogens can cause pneumonia, including bacterial, viral, and certain fungal pathogens, in particular, things like pneumocystis. We also know throughout the world, and especially where some of you may be practicing on this webinar, that we've seen a tremendous increase in multi-drug resistance. And we're really most concerned by these gram-negative resistance that are carbapenem resistant. We know that timely and appropriate antimicrobial therapy is important in decreasing mortality. Can our diagnostic tests either help us de-escalate or escalate therapy when someone has an MDRO? And how do these new multiplex tests fit in to improving outcomes? Now, here's just some inconvenient truths that we've been dealing with for decades. That for community-acquired pneumonia, which is CAP, most of the recommendations are empiric therapy because we don't identify a pathogen in almost 50% of cases. And so we haven't had the diagnostic tools to be more accurate. So we definitely need better diagnostics to more rapidly and accurately identify which patients might benefit by which antibiotic, which ones can we use narrow spectrum, and which ones do we actually need to escalate therapy to a broader spectrum because of MDRO. We now know that viruses can be important either by itself or co-infection with bacteria in as many as 15 to 30% of cases. COVID, of course, really impacted all of us around the globe. We found out, unlike things like influenza, that the second or co-infection by bacteria was terribly uncommon. Less than 5% of patients with COVID were admitted. However, the vast majority of patients, especially in the beginning of COVID, actually got antibiotics that were not necessary. And then lastly, something that we, in our critical care units and our step-down units, the diagnosis of ventilator-associated pneumonia or non-ventilator healthcare-associated pneumonias is challenging at best. Now, most of you have seen slides like this about the common community-associated pathogens. Here are the bacteria that are fairly common: Staph aureus, the pneumococcus, and Haemophilus, which has been identified in the last couple of decades being significant. Atypical bacteria will depend upon where you are. Where I actually am, Legionella, Mycoplasma, and Chlamydia are very uncommon, especially in adults. We see some Mycoplasma in younger populations. And of course, we now know increasingly that viruses can cause pneumonia in of themselves or co-infected with bacteria. On the healthcare side, we see different pathogens. Staph aureus still can be a problem, but we begin to see these nasty gram negatives. Many of them multi-drug resistant, such as Pseudomonas, Acinetobacter, Enterobacteriaceae, and in some places we see increasing Stenotrophomonas. And a lot of these tend to be multi-drug resistant, which is making our lives much more complicated. So in terms of therapy and etiology, we've already talked about early on hospital onset, Pneumococcus staph aureus. Again, some risk factors may or may not have MRSA in the United States. We're actually seeing more MSSA than MRSA now. Haemophilus has become a pathogen of interest, and we begin to see some Enterobacterialis among especially patients who have risk factors. In the late onset healthcare-associated pneumonias and ventilator-associated pneumonias, that's when we see the multi-drug resistant gram-negatives. And antibiotic selection should consider, do we have a molecular test that helps? What's the severity of the pneumonia? What's our local antibiogram show us, both in the ICU and in the non-ICU? That's often very helpful in using empiric therapy. If you know in your particular unit you have a lot of carbapenem-resistant Acinetobacter, that may, in patient who's very ill, that may influence your primary therapy. Have they had prior antibiotic exposure that might select out for something resistant? Are they immunosuppressed? And lastly, something that I can't emphasize enough is our ability to de-escalate based on antimicrobial susceptibilities and the molecular test that might indicate whether they do or do not have a resistance gene present. So this is a study done by the CDC almost a decade ago that showed the challenge. Now, we've narrowed this somewhat with new molecular tests, but I want to show you where we were 10 years ago. And these are patients with community-acquired pneumonia. And you can see that in about 50+% of cases, they were unable to identify the pathogen, and we'll get into what some of those reasons are in just a moment. But you can see for the first time, we begin to see this particular study had viral molecular studies in place. That occurred before the new lower respiratory panels became available. But you can see that in 20+%, there was a viral pathogen only. There were a number that were co-infected. And you can see that bacterial pathogen only actually was less than viral in this particular study. So this, if you look at the rhinovirus, was the rhinovirus really the cause of a lower respiratory infection or just there in the upper respiratory tract? We know that influenza can cause both upper and lower respiratory. The pneumococcus, of course, metapneumovirus, which has been a recently discovered virus in the last 20 years, we know can be fairly pathogenic. We know that RSV, especially in the elderly or in patients who have structural lung disease, can really cause significant pneumonia. Of course, we know about COVID. In certain areas, we see mycoplasma, and of course, Staph aureus and Legionella. Depending upon the area that you live, you'll know whether or not you have Legionella issues. And of course, in the hospital, we see the Enterobacteriaceae. The IDSA, the Infectious Disease Society of America, updated their guidelines from 2019 that was co-written by the American Thoracic Society, and they came up with what they call the clinical pathway for community-acquired pneumonia. And it divided it up into non-severe and severe. And so if you look at this, this is getting a little bit to diagnostic stewardship, which is one of my passions. But you can see for non-severe pneumonia, the percent positive blood culture is very low. And we're not recommending routine blood cultures for non-severe pneumonias. Those are patients who may be going to the floor rather than the ICU. However, it's severe, and there's a curve 65 or a PSI that you can use to determine severity. That's when the incidence or the positive blood cultures may go up to between 10 and 20%, but non-severe, it's less than 5%. Procalcitonin generally is not recommended for routine non-severe CAP, but it can be very useful for severe CAP, and we'll show you how that can be integrated into the molecular studies in helping guide us more appropriately. In terms of respiratory culture, I can tell you that the non-severe people, most of them do not get respiratory cultures. However, if you're considering using MRSA, they have MRSA risk factors, or you're thinking about Pseudomonas, it's really helpful to try to get a sputum culture to see whether or not you need anti-MRSA or Pseudomonas coverage, and especially if they have structural lung problems. For all severe, you should do your best to obtain a respiratory culture. We generally don't recommend for bacterial pathogens molecular testing for non-severe, but it's very, very helpful for severe. And we'll come back and talk about that in just a moment. One of the nice things about stewardship that we found is that we start someone on vancomycin, which is one of the most overused drugs in the world, that we can do a nasal MRSA screen. The negative predictive value, if you have a negative MRSA nasal swab, is about 98 to 90% in terms of ruling out that the patient has an MRSA pneumonia. So the negative predictive value is really, really high. So we recommend that in both situations. Influenza testing, depending upon whether or not you're in the influenza season, depending upon where you are. The US is now coming off a very active influenza season, mostly influenza A. Again, we've not seen much COVID this respiratory season, which is good, unlike others. But again, if you're having a lot of COVID in your community, that may be a test that you may want to look at. And then in terms of the expanded viral panels, that's certainly, if it's available, it's useful. And some of the new panels have combined both extended viral and bacterial. And again, depending upon your risk for Legionella, urinary Legionella antigen for Pneumophila type 1 is very helpful. And it's also useful for the pneumococcus as well, especially for severe disease. And we'll come back and talk about the pros and cons of that in just a moment. So here's the pneumonia panel that most of us use around. This is the most common one used around the world. And you can see it targets over 30 pathogens and a turnaround time. And I put this in the real world because once you put it on the instrument, you can get the results back in a little over an hour. But from the time that you process it, make sure you have a good specimen. The time you put it on the instrument and the time you get the results, it's really closer to 4 hours if we're being fair. The bacterial parts of these panels are what we call semi-quantitative, and I'll come back and talk more extensively about what that means. It gets the three big atypicals here and a variety of the most common viruses that we may encounter that may cause lower respiratory infections. And then very importantly, depending upon where you live in the world now, it almost doesn't matter. We're seeing increased carbapenems resistant and ESBL organisms. In the US, KPCs are the most common, although NDMs, New Delhi metallo-beta-lactamases, are increasing in incidence at a fairly substantial rate. Those of you who live in India, in that area of the world, you've been dealing with this for decades. And then you can see some other carbapenase producers, the IMP and the VIM and the OXY48. For ESBL, the most common one is CTXM. And for methicillin resistant, it's the MEC-A. That's in most of our panels, both blood culture panels and the lower respiratory panels. And you can see by looking at the sample type, the performances of these panels are remarkably good, especially if you take into account the semi-quantitative part of the panel, which I'll describe in a moment. Now, I wanted to take a moment to kind of go over one of the most common classifications for beta-lactamases. It's important to understand what these are. For the class A's, or primarily we're talking about either KPCs or we're talking about ESBLs. For ESBL, CTMXM is by far the most common gene, although we do see some SHV pluses as well. KPCs, as I said, depending upon where you are in the world, is the most common. And then for Bs, that's the New Delhi metallo-beta-lactamases. And that's in Bs. Cs are AMCs, which are more difficult to detect in terms of certain molecular studies. And then Ds are the oxalike beta-lactamases. OXY48 is the most common. It's on most panels, but I'll come back and talk about the OXY23s, 24s, and how that may be important. And then you can see here on the right-hand side, these are the inhibitors, and these are the predicted beta-lactamase phenotypes that one might use. For instance, for ESBLs, we know the carbapenems are still very active against ESBLs. And for KPCs, however, it's carbapenase resistant. If you want to inhibit the New Delhi beta-lactamase, it's S3-AM is a very useful. Now we have drugs that have S3-AM in it. For AMCs, we're looking at the third generation cephalosporins are inherently resistant, and we end up going to carbapenems. And then for the OXY48s, it gets really complicated, as you can see here. We now have sulbactam, avibactam now for these multi-drug resistant Acinetobacters. which is a really great addition to our armamentarium. Cefiderocol, which is a very interesting cephalosporin, can be used in some of these infections as well. But the concern about cefiderocol has been the development of resistance. So what's the drawback of our current diagnostic? I've kind of given you the idea what the microbiology is, what some of the challenges is, increasing antimicrobial resistance. So what are the challenges? I've already mentioned that blood cultures, especially for mild to moderate pneumonia, is very, very low. It goes up to about 15% for severe. It doesn't usually change our therapy. And if you have a low yield and you get blood cultures, contaminants may actually be more common than real pathogens, and that can lead to inappropriate therapy. Sputums in the average patient, very difficult to obtain. And so we don't have a lot of data, especially for non-critical care in terms of sputums. I try to get, if people are sick enough to be in the hospital, I try to, at all possible, to at least get some sputum so I can see what at least the patient's colonized with. And then the urinary antigens such as Legionella and pneumococcus, which I've mentioned, it does improve the the sensitivity, but remember, this is not a culture. So it doesn't provide us with susceptibilities. Now, what about the multiplex? What's some of the pros and cons? Well, there's no question it increases the sensitivity, and that's part of the challenge is how do you differentiate the sensitivity versus the specificity? And we'll come back and talk about ways that you can do that. It allows you to look at a variety of organisms with one specimen, and it does clearly improve workflow and helps you escalate and de-escalate in a much more timely manner. Obviously, you can have organisms that are maybe dead that still have genetic material you can detect. And the other challenges with some of these molecular tests, it can detect more than one pathogen. So how do you determine what the true pathogen is that you should be treating? Now, everything starts off with a good quality specimen. This is a wonderful review by John Washington. It goes back into the 1970s. And this looks at cytological screening. And these are of sputums. If it's a lower respiratory from a bronchoscopy or a patient's intubated, it's a little different. But these are ones where you get sputums. And what they were comparing was they actually did what's called a transtracheal aspirate. You actually put a catheter directly through the cricothyroid cartilage down into the lower respiratory tract with a catheter and aspirated and got a really good quality specimen free of any oropharyngeal contamination. And they correlated that with different cytological criteria. And what they found is if you had less than 10 epithelial cells, which would be squamous cells in the mouth, again, if it was bacterial, we expect to find lots of white cells, so greater than 25 white cells. This number 5 quality correlated best with the lower respiratory sampling done by the cricoid aspirate. So in many laboratories, they screen for this, and it's either reported out 2 different ways. One is few, which would be less than 10. This is more of a qualitative. Moderate would be 10 to 24, and many would be greater than 25. It's greater than 25, and you'll hear me repeat this again. That's what we call a purulent specimen, and that's going to become important in how we interpret data. So in summary, another thing about diagnostic for ventilator-associated pneumonias, if you look on the ordering side, gets to be very tricky to make the diagnosis of ventilator-associated pneumonia, and also for HAP. That we want to see new and persistent infiltrates on chest X-ray or by CTs. So often our patients have abnormal chest X-rays in the ICU because they have pulmonary edema, they have ARDS, they have atelectasis. If that's stable chest X-ray, that doesn't qualify as one of the criteria for getting a lower respiratory sample. What about purulent endotracheal secretions? How often have I heard clinicians say there's increased secretions? And they have thickened secretions. As you know, patients who have thick secretions that stay in the lower respiratory tract a long time, they can look somewhat purulent in nature. But if you really want to define that, you need to actually look at it under the microscope. And I've already defined that if you have greater than 25 polys in a regular tracheal aspirate, or at least greater than 50% polys in a BAL, if you do cell counts with BAL, that will meet the criteria of potentially being a purulent endotracheal secretion. And then worsening PEEP or and FiO2. So many of our patients have transient atelectasis. They get plugged. We suction them. We have to increase their FiO2 transiently. And then 4 to 5 hours later, they're back down at their baseline. That's not what we talk about in terms of persistent worsening. If it's transient, okay, it rarely represents pneumonia. So we look at persistent infiltrates, not pulmonary edema or atelectasis. We look at purulent endotracheal secretions, and we look at consistent worsening of PEEP and or FiO2, not transient, as indications that we should order a lower respiratory specimen. Now, in terms of the quantitation, because this becomes, I think, really important when we start looking at the specimen type. So if it's a sputum, I've already talked about the quantitative and the cytological evaluation. We look, depending upon what you read, 10 to the 5th, 10 to the 6th, and we'll be talking about copies in a little bit while, with a predominant organism that meets the clinical criteria on the previous slide. That probably represents the pathogen that's causing the pneumonia. If they have just light growth on cultures and they have low numbers and they don't have a predominant organism, that means it's probably less likely to be the pathogen. And you can go the same thing with the endotracheal tube. It looks very similar from the sputum. And then the BAL. The BAL, again, gives us a little better quality specimen. It avoids some of the oropharyngeal contamination, although it has some. And most people use 10 to the 4th as their cutoff. Again, a predominant organism, again, on gram stain. And again, if you don't have a predominant organism and you have low numbers, then that's unlikely to be a pathogen. And then if you do quantitative cultures with a protected brush, which even avoids less contamination, it's greater than 10 to the 3rd. And I want to emphasize here that none of this, okay, neither the culture nor PCR can definitively determine which positive detections are colonizers versus pathogen, and you still need clinical judgment. All these studies are really an enabler for us to make better decisions, but they should not be the driver. Our clinical judgment, taking in all the parameters that I've already alluded to, need to be taken into account to determine if a patient truly has a pneumonia. And then one cautionary note is that prior antibiotics, so many of our patients are on prior antibiotics, especially in the ICU, may impact this quantitation. And as you'll see in a moment, that does not impact the molecular study, but it does impact the typical microbiology. So let's turn our attention for the rest of the time on what this semi-quantitation means. Remember, it's only for the bacteria that this panel does semi-quantitation. And you'll see these bins. And we're talking about copies for ml. Remember, not colony-forming units for ml, but copies for ml. And as you'll see in a minute, how it correlates with the truly bacteria. But it goes down, the minimal detection is 10 to the 3.5, up to greater than 10 to the 7th. So how do we correlate that in terms of which are pathogens and which are not? This one study sort of helps us a little bit. This is both adult and pediatrics, a fairly sizable study. You can see here 48 academic medical centers. And what they were looking for is standard of care results, okay? So BAL and sputum specimens, comparing it to molecular, looking at these bin values. And as I mentioned before, they did do quantitation, semi-quantitation on the non-side, but you can see for a endotracheal aspirate or a sputum, the bin value or the copies per ml is about 1 log higher than it is for standard of care, and it's 1.5 logs higher if you do the BAL. All the resistance determinants in this particular study were detected, and you can see we have a lot of CTMXN, which is ESBLs. We have a lot of KPCs. We have some IMS. We have only 2 New Delhi metallobalactamases. I tell those of you in India, that's going to be a lot higher where you live. It's getting higher where I live. And then we look at looking at MRSA. It detects almost all the MRSA. And again, the challenge has been detecting polymicrobials and whether or not we can use these cutoffs in terms of how high the count is to determine which one's the pathogen. And so this particular one from Journal Click Micro a couple of years ago looks again at the colony forming units versus the DNA per unit. And you can see if you're greater than 10 to the 5 copies, that's bin number 5, okay? And remember, the thing about these molecular, unlike bacterial cultures, the copies are not impacted by prior antibiotics. So it gives you some nice backup. So a very high negative predictive value here, very good concordance. If you don't detect anything, the number of things you can get from bins is very, very low, 98% correlation. The same thing as you have greater than 10 to the 5th. If you have greater than 10 to the 5th copies per ml, you can see how that correlates with very, very high bacterial counts by usual methodology. So that's what we like to see. We like to see this really high count to define whether or not this is truly pathogenic. And again, the negative predictive value is very, very strong. And so that's very, very helpful. The other thing I should tell you that if you do a pneumonia panel, it always should be coupled with a culture. Even though we look for certain resistance genes, it doesn't do full susceptibilities. Remember, poor quality specimen should be repeated if at all possible. And if you have multiple pathogen panels in your hospital, it's useful to avoid redundant testing, because if the number of viral pathogens on this panel is pretty good, but if you need a more extensive panel, like for transplants, et cetera, but if you don't need that, then don't do redundant panels. Avoid repeat testing. That's not necessary. Restrict ordering. I find that most people don't know how to interpret the results of this, so you should really restrict to certain specialties who, A, know how to interpret the results and know when it should be ordered. And more importantly, you've got to educate before implementation. If you don't educate the clinicians and how to interpret it, you're going to run into problems. And the other issue is these panels are not perfect, whether you use this panel or other panels. In the one that we're talking about now, the film array panel, one of the ones that probably impact, depending upon where you work, is it doesn't, for instance, detect Stenotrophomonas. It doesn't detect pneumocystis. It also doesn't detect the OXA 23, 24, and OXA 40, and those are the ones that are pretty important in multi-drug resistant Acinetobacter, in example. So you have to know what's in your panel. And then the limitations and need for clinical correlation. We've already talked about this, understanding standard of care, that the molecular studies are not impacted by antibiotics, but the typical bacterial panels are, and that immunosuppressed or critically ill patients may develop infections with lower bacterial loads. Again, you still have to use your clinical judgment. Lastly, can we implement not just the imaging, the clinical content, the symptoms, what our latest antibiogram is, what the local pathogen are. With the molecular, can we look at inflammatory markers such as procalcitonin level? And the latest procalcitonin guidance came out in 2019 and looked at patients with moderate illness outside the ICU, looking at a variety of different scores from SOFA scores to NEWS, et cetera. Bottom line is that they primarily use the cutoff of 0.25 or greater than 0.25 to give the likelihood that somebody has a bacterial infection. And more importantly, this bottom panel is important also, because if you're going to follow procalcitonin, usually every 48 hours, when the drop occurs over 80%, or if it gets less than 0.25, you should stop the antibiotics. Often physicians get it and then they ignore the results. Also know that there are some conditions that can cause false elevation of procalcitonin, so that may alter the negative predictive value is very good, but there's a number of things that can increase procalcitonin level that are not related to a bacterial disease, including pancreatitis, trauma. If they got acute renal failure, procalcitonin is cleared by the kidney. In addition, localized infections may not increase procalcitonin. So again, in the end, you need to use your clinical judgment. If they're in the ICU, there's many things that cause inflammatory response that may increase the procalcitonin level. So they increase the cutoff to be 0.5 rather than 0.25. And some people, if they're a dialysis patient or have acute renal failure, will say even up to 1 should be the cutoff in terms of whether or not they have a bacterial infection. And the same thing applies in terms of monitoring over time and stopping the antibiotics. And again, situations such as septic shock, bacterial meningitis, there's no reason to get a procalcitonin level. You know what the diagnosis is. So if they've got septic shock, procalcitonin probably is not going to influence whether or not you start antibiotics or not. The other thing about procalcitonin level, which I'll show you on this slide, is that it really correlates very well. If you have a high procalcitonin level, you're much more likely to have a much higher quantitative count here in terms of the bins. So here, if the procalcitonin level is greater than 0.25, you're more likely to have a high count. If you look at this very nice study that was done by Dave Gilbert, really back several years ago, he used the procalcitonin level to try to differentiate sputums that had with a detected bacteria, but considered only those that had an elevated procalcitonin level to be invasive. You can see it worked very nicely because in the viral area where viruses were detected only, you can see the procalcitonin levels were very low. So it helps differentiate. And then this very nice study that came out in 2021 looks again at those copies correlating with the median procalcitonin level. So the higher the procalcitonin level, the higher the copies were by the molecular study. So you can see almost 0.5 nanogram per ml among patients had greater than 10 to the 5th copies, okay? And usually 10 to the 5th, 10 to the 6th, the ones who really get concerned that that's real. And you can see it was only 0.18 for those people who had less than 10 to the 5 copies. So that's where using that semi-quantitative really is helpful. And if you combine that with procalcitonin, I think it helps our diagnostic accuracy. So in terms of PCR results, once again, clinical judgment still remains critical. Trying to differentiate colonization versus infection can be difficult. One of the classic ones not related to pneumonia is C. diff, where the PCR for C. diff is positive whether or not you're colonized or infections. And we use a second study often to differentiate that by actually detecting toxin itself. You have to know the nuances of semi-quantitation, which I've already gone over with you today. And knowing what's on the panel and what's not. We already mentioned that things like Stenotrophomonas and pneumocystis may not be on certain panels. And you have to know when to order it, okay? And then will the physician understand how to interpret the test? And there's one healthcare system recently that implemented this panel. They are not telling the people, they're saying what's positive and what's negative, but they're not giving them the semi-quantitation, which I think is a big problem in how you interpret these tests. So my key takeaways before we turn it over to the real star, Dr. Soman, is that you got to have appropriate specimens, that no single diagnostic will meet all needs. You got to select the test, workflow, what your patients are, that the molecular tests certainly can decrease diagnostic certainty. If you get a good specimen, you report out the semi-quantitative and you know how to interpret it. There are some good institutions that don't even report out the low 10 to the 4th, 10 to the 3rd, or even 10 to the 5th. It's also very important that it's tied to your local stewardship program, that we found repeatedly that unless there's an action taken to the results of any of these molecular tests, whether it's blood cultures, lower respiratory panel, it has to be acted upon. And if it's integrated into stewardship programs, it's more likely to be acted on in a more timely manner. Understand timely decisions to optimize, discontinue, again, on a patient-by-patient. Monitor for unintended consequences anytime you implement a new test. And testing, again, must correlate with the overall clinical condition of the patient. So your clinical judgment still is important, but these tests can enable us to make more accurate diagnoses. And with that, I'm going to stop sharing, and I'm going to turn it over to Dr. Soman.
Yeah, thanks, Professor Septimus, for your excellent presentation. So, Dr. Soman, the stage is yours.
Good evening, friends, and it's indeed a great pleasure and an honor to be on this platform. And I thank Dr. Septimus for absolutely master class on pneumonia. It was just a fabulous lecture. And to follow that up with some clinical examples, it's not going to be that easy, but I'll give it my best shot. So we are going to talk on this PCR film array panel and with a focus on diagnostic and therapeutic stewardship. And I'll submit to you, friends, that both the diagnostic tests as well as our antimicrobial agents really need tender, loving care. And that's why I put up this as the first slide. So that's really the real meaning of antimicrobial as well as diagnostic stewardship. So what we want to do is to optimize the tests and the treatment, both to curtail overuse and underuse. Remember, it's not just to curtail overuse, but at the right clinical juncture, we may want to do the test as well as use treatment, which sometimes might go overboard, but we should quickly sort of come back to our senses. So it's really the right test and the right treatment for the right patient and really at the right time. So these new tests as well as new drugs need very thoughtful integration into practice in order to deal with increasingly complex pathogens, patients, and even our work environment, which is also turning even more complex. So this slide is often shown in various lectures and articles, and it's the diagnostic therapeutic stewardship. And I submit to you again that it's a continuum. We can't really have watertight compartments between diagnostic and therapeutic because it all begins with the pre-analytical phase. So there is an important role of the clinician to come to a syndromic diagnosis in which he chooses the sample and the timing, also chooses the test, and has in his mind some idea about what might be the pre-analytical probability that the particular patient has that infection and maybe that particular organism. Then it comes to the analytical phase, and that's mainly to do with the microbiologist and the laboratory. So they decide on this sample adequacy, and Dr. Septimus told us about what is a good and a bad respiratory sample for testing. And in fact, some of the samples may have to be rejected and a more invasive or maybe a tracheal aspirate sample may be actually required. After the test, then we have to correlate again, as he has emphasized so well. And now we have something like a post-test probability based on what was there and what was found in the test. The microbiologist or the clinician or both could now order some supplementary tests depending on the result. And sometimes they may even have to modify a report as well as add comments. And then again, the ball is back in the court of the clinician. So he has now to decide about the therapy. And again, that those 4 moments of antimicrobial choosing were really beautifully discussed by Dr. Septimus. So do you need the treatment? Look at the host status. Is it the appropriate agent, or sometimes a combo is required? Do I have the appropriate route and dose, and do I have an optimized PK/PD index? Is there any source control? Obviously, that's not possible in the usual pneumonia, but if you have an abscess or if you have an empyema, maybe that comes into play. Review the interactions, adverse drug reactions, and of course, de-escalate and terminate as clinically indicated. Now, where does this PCR microarray come into all this? So obviously, it can detect, and what I would say is at least a limited variety. Of course, we have a large number of organisms, but still it is a limited variety of predetermined organisms, which is based on the primers which are chosen. Now here that is important because these primers have been chosen maybe on a studies done worldwide, but they may not be entirely applicable to every small region of the world. The test definitely has good test performance in terms of sensitivity and specificity. And for clinicians in resource limited settings, maybe I'm from one of them, this is really a leapfrogging innovation that helps to catch up without all the intermediary steps. The simple example is we never had any case diagnosed with human metapneumovirus. I mean, it was just not possible. So here we have a test which is suddenly giving us so many viruses, and most clinicians are struggling to find out what is the real significance of those. But ordering test is simply an instinct, like a dog chasing a car. First, the clinician has to consider what to do if something is found or if nothing is found. Now, as Dr. Septimus has emphasized, a molecular test may or may not represent viable organisms. And even if it does, they may be colonizers at normally non-sterile sites. So again, the test will never tell you. That's the business of the clinician to decide whether it's a colonizer or an invader. Also, this test's accuracy potentially exceeds that of its predecessors. So we had cultures, we had other tests, and they were not really that good. So it may appear to be less specific because it is picking up many more organisms, or sometimes it might be less sensitive. Against what? Against an imperfect reference, as the right answer is unknown. So we don't know whether even culture is the gold standard. So in this situation, what can we do? We can have multi-test comparators. So this is the solution which is possible. So this is going to be the clinical adjudication, and there has been an excellent paper by Dr. Falsey and about the clinical adjudication. And all this actually emulates the clinical practice of putting multiple inputs together. So the clinician is not going to go only by the test, but also by the radiology, by the clinical features, and so on. So I'll give you a few examples. And again, I mean, I had not actually heard Dr. Septimus' lecture, but you will find out how many of his messages are coming out through these case examples. So here we have an elderly patient who was admitted elsewhere and received a large dose of steroids for lumbar spinal stenosis. He developed a UTI with a CR, that is carbapenem-resistant Pseudomonas, and was treated with colistin elsewhere, which led to nephrotoxicity. He developed marked drowsiness, and yet they somehow continued to give him feeds, which probably led to aspiration, maybe also pulmonary edema, and was transferred to our institution. So we found that he had severe hypotension, hypoxia, he was ventilated, and we had a review of his previous X-rays, which showed that within a space of 1 day, a marked infiltrate had developed, especially in the right mid-zone, lower zone, also a little bit on the left side. So this was indicative of an aspiration pneumonia. We did his blood culture, a beta-glucan, a tracheal aspirate LRTI multiplex PCR, the one which we are talking about, as well as a tracheal aspirate culture. At this moment, the patient was too unstable even to do a high-resolution CT scan, and the patient was now given empirically, so to say, ceftazidime, avibactam, and aztreonam, along with metronidazole and micafungin, and SLED was started. Now, these are the results of his lower respiratory panel. So you have bacteria, you have certain resistance markers. So you have 10 raised to 4 bin values of Enterobacter cloacae, Klebsiella pneumoniae, and Staph aureus. You have CTXM. Again, Dr. Septimus told us of the Ambler classification. So you have CTXM, the MEK obviously, and MREJ came from the Staph aureus. NDM and OXA48 like was also detected, which obviously came from these gram-negative organisms. Additionally, endemic coronavirus was also found. We did a LFD, or a lateral flow device test, which can quickly tell us about galactomannan. So from the tracheal aspirate, the galactomannan was also positive, which is a little off-label way of doing it. But we also had it from the serum, which was also strongly positive, and also the beta-glucan in the serum was positive. So how can we analyze this case? Look at the various host factors, the clinical features, the radiologic findings, the microbiological tests, organisms which have been found in the non-culture based tests, and what might be suspected, and what empiric therapy can we devise at this moment who's in a patient who's seriously ill. So this patient had been drowsy, feeding had been given, so strong suspicion of an aspiration of the upper respiratory contents or even the upper respiratory organisms. Now we found that there was a rapid increase in this infiltrate, which was definitely looking like a aspiration pneumonia. The anatomic location was also characteristic. Now we did find all these organisms with these resistance markers, and certainly many of them, or maybe all of them, could be colonizers. But here you have a setting where the person has probably aspirated whatever was there in his upper respiratory tract. So can we just call them as colonizers, or do we need to do something about it? So that was the question. Additionally, the patient might have anaerobes, which have to be suspected. And remember that the treatment which was given, like ceftazidime, avibactam, aztreonam, does not work for the anaerobes. So you need additionally metronidazole. Now, this patient had received steroids for that spinal problem, and he also had an endemic coronavirus. You saw that there was a infiltrate which did look nodular, and we found that the tests for aspergillus were also positive. So that has to be suspected in this situation. And maybe what we did was to start with isavuconazole, and then micafungin, which was also started, would be perhaps helpful for aspergillus as a second drug. Now, this patient had come from another hospital, so he had a very poorly maintained central line, and the patient also had fever, hypotension. So, was there some other cause like a bacteremia or fungemia which was giving him this fever and hypotension? So, that was the next question. And the BDG, which was very high in his serum, could indicate perhaps that there was candidemia, which could have come from the line which was poorly maintained, and therefore the micafungin could help in that situation. Now, receipt of steroids, dyspnea, hypoxemia. However, there was no characteristic infiltrate of the ground glass appearance in the perihilar region, which we suspect in pneumocystis pneumonia. It wasn't there, and also it was just a short exposure to steroids. So we didn't really consider pneumocystis as one of the important differential diagnoses. It appeared to be less likely. But in the beginning, even that micafungin which we are giving for suspected candidemia can perhaps help at least to begin treatment for pneumocystis. So not surprisingly, E. faecalis, as well as Candida glabrata were isolated from his blood culture, and they were treated with whatever we were giving. Now the patient stabilized, his HRCT of the chest was done. And what you find here are the GGOs, the ground glass opacities with crazy paving. We also found nodules as well as some which were looking confluent with halos and consolidation, which was consistent with the virus, that is the endemic coronavirus, invasive pulmonary aspergillosis, and bacterial pneumonia that was probably likely due to the aspiration. And with all this treatment, the patient improved. So the messages which come out from this case are certainly host factors, clinical features, radiological findings, and a microbiological test. All of them can help to adjudicate the results of a non-culture based test such as the pneumonia panel. Now you had multiple organisms there, 2 or 3 gram positive, gram negative and 1 gram positive, but all of them had low bin values. So again, Dr. Septimus has also told us that low bin values probably reflect colonization, and when there are so many of them there, very likely that all of them are colonizers. But really in this patient, we do need treatment in the setting of aspiration. Also, we may have to consider what other organisms may be present which are outside the scope of this PCR test and may be important, along with what might be their resistance mechanisms. So all this proper interpretation of the test, the strengths, limitations of the test can really optimize treatment and thus ensure stewardship. Again, I'm reminding you that it's not just not giving treatment or withholding treatment, but having a rational and appropriate treatment at the right time. That is going to be the meaning of stewardship. Now, this is an example where we use this panel but treated only for one organism. And let's see how we can do that. So this was a 35-year-old lady with fever, myalgia, mild cough. The WBC was normal. She was started on ceftriaxone and azithromycin, commonly used in community-acquired pneumonia, and the patient was referred for an ID opinion. So in her case, also the sputum was of good quality, and it showed 10 raised to 5 Acinetobacter, 10 raised to 4 Haemophilus influenzae, and there was NDM marked as the resistance marker, and we also had Mycoplasma pneumoniae. So how would we analyze this case? Now, Acinetobacter with NDM is certainly not a cause of community-acquired pneumonia. Again, Dr. Septimus told us that it clearly goes into the hospital-acquired pneumonia business. Haemophilus influenzae was found here, can produce a pneumonia in the community, but it has really low bin values, just 10 raised to 4, just about makes the grade. in this situation, so it certainly can be a colonizer. However, Mycoplasma pneumonia presents with a systemic illness as this patient had. Just note that she had fever, myalgia, and really very mild cough. There was no clear lobar consolidation. A WBC was normal. You just had a mild dizziness in the left lower zone. So what really means is this mycoplasma seems to be the most important thing here. Now, these atypical bacteria as well as some of the viruses are generally not thought to colonize airways, and their presence suggests active infection, although there are a few studies which show that maybe rarely it can also be a colonizer. Now, the local epidemiology comes in here again. Now, resistance to macrolides in Mycoplasma pneumonia has been seen in Asia. And recently in India, we had a lot of cases, certainly, and Mycoplasma is known to come in crops. So, hence the treatment was changed to doxycycline alone. So, again, need to analyze the clinical picture as well as the PCR report. And when the organism is likely to be, whether the organism is likely to be a colonizer as the Haemophilus, as well as maybe even Acinetobacter in this case, or does it really indicate current infection? And we need to have this epidemiological knowledge, which obviously the PCR panel is not going to provide us, about what is currently circulating and being a cause of pneumonia, as well as the susceptibility and resistance. Now, clinical laboratories are not going to tell us anything about susceptibility of mycoplasma. So you need to know what is being published in the literature, what is common in this area of Asia, and then treat accordingly. And this case, this is the third one, which says that we used the pneumonia panel and actually treated none of them which were detected. So this was a somewhat old case. So this was a 33-year-old previously healthy lady. She presented to us in 2021. Remember, that was the time when there were a lot of COVID or SARS-CoV-2 going on with features of CAP. And as you can see, there is a large consolidation there with the air bronchogram and so on. But the SARS-CoV-2 test was negative. Her WBC count was normal. So she was being treated by a physician with piptazo, with azithromycin, and also with oseltamivir. And this test was done for her. So what was found here was Klebsiella pneumoniae, 10 raised to 4, pseudo-aeruginosa, 10 raised to 4, and also Serratia marcescens. And what resistance markers were there? CTXM, NDM. And also what was detected was the endemic coronavirus. So interestingly, the physician said that he would like to start on ceftazidime, maybe Bactrim and Astronam. Obviously, he is concerned about the NDM part of it, but at least he has written, if I agree. Okay, so how do we analyze this case? Now, this was a young lady. She had no comorbidities, no prior healthcare exposure, neither antibiotics. WBC was normal. She had 3 GNBs with low bin values. No atypicals or influenza were found. Now, endemic coronavirus is never a colonizer. So you must know what is the spectrum of disease. Often it is a very mild illness, but sometimes it can produce all the features which this patient had, such as consolidation, nodules, and so on. But does it have any specific antiviral treatment? Answer is no. And hence no antimicrobials were advised for this case. So here you would go by what messages come up. So this really is a good example of empiric or reflex, or sometimes what we call as knee-jerk prescribing versus reflective prescribing, where you think a little more about the case. So recommendations and restrictions now on antibiotic use led by a clinical pharmacist often have low acceptance rates in India. You know, in India, this sort of a specialty is still in its infancy, and we don't have that kind of clinical pharmacists or ID clinical pharmacists as are present in United States and elsewhere, who are really, really experts in their field. So, and if these clinical pharmacists go on rounds and advise physicians, there is an issue there, and it's a problem to advise those who have not even requested it. On the other hand, we sometimes call what is a handshake stewardship, which is more effective. So the ID physician is going to talk to the primary physician and then take up the responsibility of the case. He analyzes the case as well as explains to that physician what he's thinking about. So it all depends on the ID physician's credibility, sharing of responsibility. So when the ID physician says, okay, de-escalate or do not treat and so on, he's also taking responsibility. And that leads to a sustained long-term relationship with the primary unit. So some of my concluding thoughts. So we have this PCR film array panel. It does provide very, very useful information, but the results can't be interpreted in isolation. They are complementary, friends. They are not competitive with conventional practice. So what do we need to interpret them effectively? So we need basic microbiology, smear culture, drug susceptibility tests, serology, biomarkers, everything. Knowledge of the local epidemiology of infecting organisms, their resistance patterns, the mechanisms of resistance, and some of them are there in the panel, but others are not. And again, Dr. Septimus told us about OXA 2351 and other Acinetobacter-related OXAs. And certainly it needs clinical acumen in a good measure, thankfully. It saves our job for some more time to have the best impact. So this clinical impact can vary with the specific local practice conditions and a large number of other factors. And that's why I would say what is the real way to measure the clinical impact? So let's start at the bottom. We definitely have a test which detects and is very efficient in the laboratory. Does it have diagnostic accuracy, efficacy? In other words, does it distinguish between patients with and without the infection? How does it influence the diagnostic thinking efficacy? So does it influence the diagnostic pathway? And certainly it does. So when you have something which is found to be a test which is negative, the clinician must now start thinking about what are off-panel organisms. And Dr. Septimus again told us about Stenotrophomonas, and certain other bacteria. But depending on our local epidemiology, it could be TB, it could be, if it's immunocompromised, it could be nocardia, it could be an invasive mold infection, and so many other things which are not represented. Melioidosis is also something which we think of in our country, in some parts of our country. Then does it lead to therapeutic efficacy? So does it help really to start, change, stop, or avert treatment? And each one of these words are very, very important. Finally, does it make any great difference to the patient? So was there an outcome difference? So do patients who have the test fare in any way better than those who did not have the test at all? And the last part of it is also very important, and that is called as societal efficacy. So is the test cost effective and acceptable, which is based on very complex trade-offs, and they would be different in different societies. So, resources which are sort of have to be diverted for this test if the government is paying for it. And then these resources are diverted from other areas which might be perhaps more essential and so on. So this is very complex, and I think it is something beyond the purview of the clinicians. And that brings me to what is sometimes called as a RLS, or a resource limited setting paradox. It's often said that PCR film array panels are certainly difficult to use due to the cost and due to resource limitation. And in this situation, maybe empiric treatment can be a solution in resource limited settings. However, I will submit to you that the costliest treatment, mainly antibiotics, is one that does not work. And in resource limited settings, microbiology facilities, which I told you is really the backbone, and ID expertise are both unlikely to be available. And paradoxically, PCR film array panels might actually be inexpensive ways to get the desired information and optimize treatment. Okay, so I really leave you with this particular paradox. I mean, don't you think it's paradoxical that the most glorious colors come just before the fall? Yeah, so in contradiction and paradox, you can find truth. So really speaking, I'll again sort of say that in resource limited settings also, one must consider the use of these tests, which might go a long way in stewardship. Thank you so much. I'll stop my screen share now.
Thanks, Professor Septimus and Dr. Soman, for your outstanding and very complimentary presentation. Now we can move to I think, another interesting part. This is the interactive poll question. We will have totally 5 poll questions. if I can have the first question on the screen. So here you have it. So the first one is about the factor to consider when interpreting the multiplex PCR report. So as you see below, you have multiple, possible answers. So the first one is host factors. Second one, timing of specimen collection, especially, in relation to antibiotic or antimicrobial prescription, administration. The third one, specimen type, if you are dealing with sputum, endotracheal aspirate or bronchoalveolar lavage. Latest local epidemiology and antibiogram reference, clinical feature, microbiological test, inflammatory biomarkers, or you consider that all the factors listed here and they are all important. So I give you 30 seconds to give your reply, and then we will look at the results. May we have a look on the result if we have enough reply already? Oh, it's quite, I would say, quite divided in the different factor we describe. Yes. So maybe I think it would be interesting to have the few comments from the speaker, like Dr. Septimus and Professor Septimus and Dr. Soman. Yeah.
Well, it's a complex question, which may confuse
That's
folks.
true,
but
that's
I think based on the wonderful cases that Dr. Soman reported and some of the information that I presented in the beginning, I'll come back and talk about clinical judgment and trying to integrate all the signs and symptoms clinically and apply that to the bedside to the patient that you're seeing. So I would have answered this all of the above. Depending upon what's available. Not everybody has a BAL, et cetera, but you should know your local antibiogram. You should obviously review the clinical symptoms, what typical microbiological results are available. If you have procalcitonin, that may be useful as well. And of course, the host. I think all of those should be taken into account when deciding on therapeutic. So I would have answered all of the above.
Yeah, I agree. And this is what the audience did also. Almost 80% of the participants choose all the above as well. Okay. So let's move to the second question. Yes, so you have it. Do you use semi-quantitative threshold to report positive detection in case of polymicrobial detection? So just here, single choice, yes or no. So just a few seconds. Yeah, I think it's easier. May we have a look on the result for this one? Okay, so here you can see 84% of the participant replied that yes, they use a semi-quantitative threshold to report positive detection in case of polymicrobial detection. Yeah. Professor Septimus, so Dr. Soman, any comment on that?
Yeah, this question pertains to PCR, or what is it, or it's just the routine culture?
Pertain to the Pneumonia Panel and Multiplex PCR.
Yeah, so that is automatic that you get the semi-quantitative bin values, and it's for you to interpret which one of them stands out much more than all the others. And while we are on this topic, I'd just like to inform Dr. Septimus perhaps that somehow Staph aureus is not an important pneumonia organism in large parts of India. So many recommendations which involve that, and sometimes we do recover a low number of Staph aureus, and then we don't pay too much attention to that because most of the problems, even in hospital acquired and ventilator associated, are related to gram negatives. But certainly, coming to the question, it's very, very important to pay attention to the bin values.
Let me ask Dr. Soman a question. I'm an old timer, okay? And I still like gram stains. It helps determine whether or not it's a purulent specimen or not. But I always tell the house staff that you need to correlate gram stains with cultures. We're not talking about molecular, we're talking about just basic microbiology. And what really is confusing, and I'm sure this is the case for most of you that are on this call, is that you'll see the gram stain.
I
And it'll say,
absolutely heartily agree.
see a few gram-positive cocci, and then the culture says many gram-negative rods. And we see
Right.
this, we see this all the time. And how do you interpret that? And I think that's when things get a little bit more difficult. But if you see things on gram stain that are obviously do not grow culture-wise, if you're doing just plain old typical microbiology, some of them may be anaerobes. But it is useful to correlate because you need about 10 to the fourth, 10 to the fifth organisms to see them on gram
Yes.
stain. But it is interesting how often we see a sort of a discordance
Yeah.
between what we see under the gram stain and what actually grows. So I'm curious with Dr. Soman's experience with that because it's confusing to me, and I've been doing this for a while.
Absolutely. I think it's a very important clinical point, which brings us back to earth. Rather than having these, I mean, so obviously we need all these new tests, but we have to be firmly grounded. I keep telling my fellows that read the entire report. The microbiologist has taken pains to look at the gram stain and done so many things. You at least spend time trying to read the report and make some sense of it. I think it's very important. And even sometimes it's even said that if you find intracellular bacteria, it's certainly something which is very, very important. So, sometimes capsulated strep pneumo and such things can easily be seen. And if they are forming the majority of the bugs on the slide, obviously that is the true pathogen which we can't afford to uh, pay attention to it, of course. Polymicrobial again can tell you that it could be a bad specimen, or maybe it's a mixed bad infection, maybe a aspiration pneumonia as in this patient, or a lung abscess and such things. So gram stain is invaluable and it remains like that even today.
Yeah. So we will further discuss about semi-quantitative threshold. So let's move to the third question. So the first one is, in the situation of no antimicrobial resistant gene detected, what is your semi-quantitative threshold you apply to report positive detection in endotracheal spirals sputum specimen? 10 to the 4 copy per ml, 10 to the 5, 10 to the 6, or 10 to the 7 copy per ml? So again, I'll leave you just a few seconds. It's quite, I think, easy to reply here. Okay, so we already have the result. So majority of the people, they choose 10 to the 5 copy per ml as a semi-quantitative threshold for ETA and sputum. What do you think, Dr. Soman or Professor Septimus, of the choice of, from the audience?
That's a tough question.
No, based on your experience, if I ask you the same question, will you choose the same threshold or a different one?
Well, you told me I couldn't vote, but okay. But this is tricky. One of the slides that I showed was trying to correlate the different bins with colony forming units. And I would certainly discount the 10 to the 4th. 10 to the 6th, 10 to the 7th gets my attention. And 10 to the 5th, I would say is the minimal threshold, but I prefer to see predominant organism in a 10 to the 6th, 10 to the 7th bin as more suggestive of invasive disease. But Dr. Soman, I'd love to hear his input as well.
Yeah.
Yeah. My sense is like this, that I think the clinician must first judge which organism is important and then pay attention to the resistance markers later. Because there is also an issue, like obviously if you have a Staph aureus there, then the MK and the MREJ is coming from that organism. But for the others, sometimes you don't know. Like for example, in India, Klebsiella pneumoniae is often an NDM producer, but so is Pseudomonas and even Acinetobacter. And therefore, it is difficult to judge like this NDM is coming from this or that organism. Obviously, OXA 48, like enzymes would be coming from Klebsiella and not really much from Acinetobacter and Pseudomonas. But this is a secondary question, according to me. The primary thing is which is the organism, how much what is the bin value, and how does the clinician think about that organism as being the predominant one. And once you make that judgment, then you look at the resistance markers. I think it should not be done the other way around. And then finally, if you do not find the AMR gene, then you must know whether that particular organism is expected to produce an AMR mechanism which is not represented in the PCR panel. Now that's certainly the case, and we both of us talked about Acinetobacter having OXA, not OXA 48, but 23, 51, and so on. So obviously the test can't pick them up. So if somebody finds Acinetobacter there in India, then one has to think of these as well. And India thankfully is there in that. So in order to fashion treatment for that Acinetobacter, one will have to think of all these resistance mechanisms which it is known to possess and which may not be present in the panel. Thanks.
Okay, thanks. Thanks to both of you. So let's move to the first question. Again, I mean, continuing to talk about semi-quantitative threshold. So this one is basically the same question, but in this time not for sputum or ETA. This is for BL and mini BL specimen. So again, same question. What is the semi-quantitative threshold you will apply to report positive detection? 10 to the 4, 10 to the 5, 10 to the 6, or 10 to the 7, but for BL or mini BL at this time.
Can I take this question? Dr. Septimus already told us about the previous published data, which talks about 10 raised to 4 for BAL specimens. I don't know really what is the threshold for mini BAL. But for BAL, it has been found to be 10 raised to 4. For the protected specimen, 10 raised to 3. And obviously 10 times lesser if the patient has been on a appropriate or relevant antibiotic. So these might be considered thresholds, but at the bottom line again is even if you have these thresholds and making a judgment whether that is just a colonizer or a true pathogen, it's not so easy. Remember that these will have a good negative predictive value and not a very good positive predictive value. In other words, if you find low index values or low copy numbers by whatever means, it will have a good negative predictive value. Rather than saying that, okay, we have found the organism, this is the organism because this is in 10 raised to 4 copies in a BAL specimen. On the other hand, if you hadn't found it, it is a strong point in favor saying that this is not the organism and maybe that which is producing the problem. I'd like to have Dr. Septimus' thoughts on this.
Another difficult question. Obviously, the number of copies, the better the specimen if it's low respiratory. But if you look at that original slide, Richard, that you showed right from the beginning, that picture of the lung and the number of copies per ml, I kind of still lean towards the higher number of 10 to the 4th, 10 to the 5th and above, even for BALs. I will say that, some communities report out, as you saw, Dr. Soman, they gave you the printout exactly what the bin was for all the organisms that are isolated, which is fine, as long as the clinicians looking at that know how to interpret it. There are other places where they sort of suppress the low numbers and only show you the higher number of copies. So I think it depends upon your community, what the education of the physicians are. But I still look more at the higher number of copies as potentially being more significant. At the 10 to the 4th, even for BALs, I still think is a relatively low number of copies. Certainly, if I get 10 to the 6th, 10 to the 7th, and it's by far the predominant organism and all the clinical signs and symptoms that I reviewed were present, I'm more likely to say that's the pathogen. And again, there are nuances here, and there are some gray areas, which I think Dr. Soman's case has certainly demonstrated, where again you still have to go back and use your best clinical judgment as to how to interpret these tests. Again, they're enablers, but they shouldn't be the drivers that you use. Remember, these molecular studies are not influenced by prior antibiotics. Your regular microbiologically are. And so I still think that the number of, again, copies per ml still are relatively accurate, even if they're received, because so many of our patients that are ill in the hospital, they've already gotten antibiotics. And so the usual semi-quantitative results may be skewed by that. But I would look again for the higher numbers, whether it's more predominant in terms of if you could culture multiple things, let's say a couple of them are 10 to the fourth, but you got one that's 10 to the sixth. I go with a higher number if that's the one I'm going to choose to treat.
Thank you. So let's move to the last question. So in the situation, if you detect, one or more antimicrobial resistant gene detected, do you use semi-quantitative threshold to report positive bacterial detection? Yes or no, then you report all the bacteria findings. Again, just a few seconds to reply. May we have the reply from the audience to have a look? Okay, it's a little bit share between yes and no. Again, comments from Professor Septimus and Dr. Soman.
You didn't tell me there were going to be such difficult questions.
They are difficult, a tricky question, but very important.
No, but actually, let me say this. There's probably a reason to, I'll tell you why there's probably a reason to report them out. Even if one of the most difficult things we see, and I'm sure Dr. Soman's the same way, especially in the respiratory ventilator patient, is trying to differentiate those that are colonized and those that have invasive disease. We see a lot of that with Stenotrophomonas and with Acinetobacter, really difficult times to decide. But one reason for making sure we report this out is even if you decide it's a colonizer, there are some infection prevention issues that you need to consider. If you've got an MDRO, you want to make sure that patient gets appropriately isolated and that the staff knows what the appropriate PPE is in managing those patients. So there is a reason, I think, to have that information. But just because they have a resistance gene in and of itself doesn't necessarily mean that the organism is invasive or not. But I do think it's useful for infection prevention perspective.
Dr. Soman?
Very true. Because you could have an organism which is really devoid of a lot of resistance mechanisms. So probably that is not going to receive the same. Ideally, all patients should receive enough, contact precautions and maybe one-to-one nursing and so on. But depending on the actual practice conditions, that might not be always possible. In which case, you will have to prioritize the all your infection control practices for that particular patient who's got a bug which is having a lot of resistance genes. And regardless of even if it's just a colonizer or it is a true pathogen, because that is going to impact that individual patient's treatment. But infection control practices would be regardless of whether it's a colonizer or it's a true invading pathogen. So that is a very important message. And again, coming to Stenotrophomonas, many of its resistance mechanisms are not captured by the PCR test. And therefore, we have to, and there's so many other complex issues of testing the bug as well as fashioning appropriate treatment, having proper breakpoints and clinical relevance of those MICs, all are complex issues. So I think for Stenotrophomonas, it's going to be quite a difficult challenge using any of these tests. Thanks.
Thank you. We have finished the interactive poll question. So thanks to the audience and the speaker for your participation. It was very insightful and interesting. I saw we have some question in the Q&A chat. So I just want, maybe we will not have time to reply to everything, but at least I want to pick up some of them. Let me have a look. So the first one from Dr. Kochi, let me to read it. Will integrating a structured pre-test probability assessment into ICU admission protocol improve the appropriateness of biofire testing, okay, and reduce unnecessary test utilization? What should be the threshold of clinical suspicion above which biofire results significantly alter ICU patient outcome, especially when multiple pathogens are identified? I mean, we come back to how to interpret, the result when you have multiple pathogens, but here we are talking about ICU patient. Who want to comment on this question from Dr. Kochi?
Is it there in the chat box? I couldn't exactly pick up. Is it written down somewhere?
In the Q&A chat.
Which was the question number?
This is a question from Dr. Kochi. Maybe I can, let me.
Is that the first one? That's the first one, Richard?
Okay, that.
First one, yeah.
Yeah, it says, well, integrating a structured pre-test, is that the one?
Yeah.
The pre-probability assessment into ICU admission protocols improve the appropriateness of biofire testing and reduced unnecessary test utilization. And what should be the threshold of clinical suspicion above which biofire results significantly alter ICU patient outcomes, especially when multiple pathogens are identified? So did I get that right, Richard? Is that the one you're trying to have this answer?
Yeah.
Certainly, I think this kind of, I don't know whether it should be a structured pre-test probability, but even in the slide that I mentioned about diagnostic and therapeutic stewardship, the first part of it begins with the clinician making some idea about what might be the pre-test probability of not only that particular syndrome being there, and perhaps what organisms might be anticipated. So that pre-test probability assessment is very, very essential. All these tests, after all, they are non-culture based tests. So by themselves, they do not indicate disease. Okay, so they will have a good positive predictive value if your pre-test test probability is high. So that's true of other biomarkers too. You could have a galactomannan or a beta-glucan with very, very low pre-test probability, and then it's very likely that those tests are false positive rather than truly positive. So I think it is very essential that this pre-test probability has to be assessed in the mind of the clinician. What you really mean by a structured pre-test probability, I really don't know. Whether some percentage of 10-15% or whatever, can anyone put down that in terms of numerical value? I'm not so sure about it. All that we can possibly think is, yes, this patient has a high pre-test probability or a low. That's all I can say. While we are on this topic, you could think about different varieties of intra-abdominal candidiasis or candidemia in an ICU patient. Sorry, I'm digressing it to a different into a different area, but it's very well known what is the pre-test likelihood of somebody who gets a bowel perforation or acute pancreatitis and so on. And in that way, you can actually classify that patient whether beta-glucan is going to raise that pre-test probability to a post-test probability which is higher than the threshold which you would use for starting treatment. I don't know whether I've answered your question, but that's what I think.
Yeah, thanks a lot. So next question, I mean, this is more question about talking about, what kind of clinical specimen for children. What specimen is recommended in children less than 5 years? I guess this is we are talking about the Pneumonia Panel. So according to your experience, if you have to deal with a, with the child, what you will do if, you still want, to use the pneumonia panel, which clinical sample, you are thinking about?
I honestly don't have any experience with that age group, so
Okay.
I personally can't answer that, but it's a
Yeah.
good.
Dr. Soman, from your side, any experience about?
Yeah, again, no experience.
Okay,
Zero
okay. It's okay. That's okay. Usually, they I think for kids they are more using. If this is again using the pneumonia panel, they would probably use ETA because of course they cannot produce usually sputum. And then there is a question about aspiration pneumonia, Klebsiella, E. coli, Pseudomonas. Which one to consider between these three, according to your experience?
Sorry, again, in a case of aspiration pneumonia, what would you consider significant? Klebsiella, pseudo, and
Klebsiella, between Klebsiella, E. coli, and Pseudomonas.
okay. So see, Pseudomonas won't be important organisms of the gastrointestinal tract, and therefore, even if you have some retrograde colonization of the stomach, which might produce aspiration pneumonia, it's more going to be E. coli and Klebsiella. On the other hand, Pseudomonas can come from the hands of healthcare workers or other things in the hospital and might colonize the oropharyngeal flora. Now, finally, when the patient aspirates, he might aspirate everything. So he might aspirate what was there, regardless of the route of arrival in the nasopharynx or in the upper respiratory tract, whether it comes from the hospital, comes from healthcare workers' hands, or it comes from his own bowel, and because of retrograde peristalsis or microbial colonization, all of them ultimately will find their way because of microaspiration or a gross aspiration into the lower respiratory system. So all of them can be involved in that. It will be difficult to say that which one of them is more important. Clearly, two of them are bowel organisms and one of them is coming from the hospital, but all of them can do that. Like, for example, Acinetobacter won't come from the bowel, but would all obviously come from the hospital environment.
Okay, thank you. Maybe the last question, because we are over the time already. A good number of neutrophils presence or absence. Basically looking at the white blood cells count. If to try to decide if the pathogen, the bacteria detect is a colonizer or pathogen, or bacteria or virus, depending.
Yeah, let me answer that. If the patient's not neutropenic, and that is the only caveat that I'll give, okay? One of the criteria that I do use is whether or not someone has a purulent specimen. So especially if someone's on a ventilator, if I see someone who has vague, nonspecific changes, and they collect a tracheal aspirate, and that tracheal aspirate shows only few white cells, that really decreases my suspicion that whatever is growing is truly pathogenic, and whether or not the patient truly has a bacterial pneumonia. And that's a little different. Occasionally, we do see nosocomial viral pneumonias, but in general, if we're looking at bacterial pneumonias in the intensive care unit on someone who's on a ventilator or not on a ventilator, I remember I went through some of the signs and symptoms: persistent changes in FiO2 or PEEP, purulent specimen, clearly persistent changes on chest X-ray beyond just pulmonary edema, ARDS, or atelectasis. If that all aligns with a purulent specimen, I'm more likely to think that patient has pneumonia. If the patient doesn't have all those, and the patient doesn't have a purulent specimen, meaning many white cells, then I tend to think that whatever grows is mostly colonization, and the patient truly doesn't have pneumonia. So I use all of those clinical parameters. BALs are a little bit trickier because there is some dilution when you do BALs. And as I mentioned in one of my slides, it's useful to get a cell count on BALs. And they should see at least 50% neutrophils on cell counts to be in the ballpark that it may be a purulent specimen. But it's a little bit different for BALs. That's why I think getting cell counts in BALs is helpful. getting a straight gram stain on the sputum or tracheal aspirate is adequate. But for BALs, you can do a gram stain, but you also probably ought to do a cell count.
Thank you. So, thank you, Professor Septimus and Dr. Soman, for taking the time to share your insight and experiences regarding the use and the importance of the Pneumonia Panel for the management of patients with lower respiratory tract infection. Thanks so much. I also would like, to express my gratitude to the audience for your interest and participation today. As we would love to have your feedback on this webinar, you have a link to a survey in the Q&A box, and we will send you your certificate of participation as soon as the online survey has been completed. Thanks a lot, and we look forward to seeing you at the next webinar. Thank you. Thank you all. Bye.
Thank you.
Thank you all.
Dr.
Bye-bye.
Septimus, I enjoyed listening to you. It was a superb lecture, no question.
I think we all
I love your cases. I think it was great to be with you. Thank you so much.
Thank you.
Thank you. Bye.
Bye.